know, for some people it might be later evening. For others of us, it's early evening. And so I am very much looking forward today to speaking to you about two things that I see very, very commonly in my practice, fibroids and endometriosis. And for my role, so yes, I'm, as Stacy alluded to, I'm an assistant clinical professor at UCR School of Medicine and practice at UCR Women's Health. I also help teach the third year medical students. I feel very passionately that medical education is very important, and try to impart some of the knowledge that I have to our students, so hopefully they can carry it forward into their own practices. And so with that, we'll go ahead and get started. So quick disclaimers, just that the contents of this presentation are not intended to be medical advice. They certainly don't replace consultation with a gynecologist or a medical professional, and that I am an employee of the University of California, Riverside. So I usually like starting by outlining what I hope you will take away from the presentation. And so I hope you will be able to recognize these symptoms and treatment options for fibroids, as well as recognize the symptoms and management options for endometriosis. And so I like to think of these talks as almost like a call to action. So of course I want to educate those of you who are here attending, but I would charge each of you to spread the word regarding these conditions to help educate other folks. And we'll dive a little bit deeper into that as we get into the talk. So first thing, we'll go ahead and discuss fibroids. So fibroids have many names. They may be called leiomyoma if there's just one of them, leiomyomata if there's more than one, or just myomata. That comes from the myo meaning muscle. So this essentially is a overgrowth or sort of a replication of one cell in the muscular layer of the uterus that is kind of growing a little bit more quickly than the surrounding cells. And so fibroids are actually very, very common. They're found in up to 80% of women. Some women actually go their entire lives never even knowing that they have them, because if they never had an imaging study done on their pelvis or never have any symptoms from them, then they may not even know that they exist. And so the medical definition is a benign smooth muscle neoplasm that typically originate from the myometrium. And so we have a couple of pictures here. I'll just kind of orient you here. Let me get my laser pointer going. So this is what a fibroid looks like when you're looking at it from using the naked eye. So if we do a hysterectomy or removal of the uterus on a woman, we happen to cut the uterus open, we might see these masses here. And this is actually a fibroid that's been cut in half. You can see it's actually, you know, this material or tissue actually looks quite different from the surrounding regular myometrium. So it typically they sit within a capsule, and there's a distinct demarcation between the end of the fibroid and the beginning of the myometrium, or vice versa. This slide in the lower right-hand corner is more of a microscopic view. So this might be what a pathologist looks at when they're making slides underneath the microscope. And this basically shows you that the fibroid, or the L, leiomyoma, has many more nuclei per field than does the regular myometrium. Okay, so just kind of two different ways to look at it. Another way we talk about fibroids is where they're located in relationship to the uterus. And so, you know, there's different ways that we can classify them. There's different classification systems. If we're mainly just using descriptive words, then a lot of times you may hear me or a medical professional talk about a submucous fibroid being something that's resting right below the endometrium, which is the lining of the uterus, okay? An intramural, which doesn't touch the lining of the uterus and also doesn't touch the surface of the uterus. So intra meaning within and mural meaning wall. And then a serosal fibroid, which is where the fibroid touches that outside surface of the uterus, which is also called the serosa. You may also hear about a pedunculated fibroid, which could either be pedunculated within the cavity of the uterus, or it could be pedunculated hanging off the top of the uterus. And then a couple other words you might hear about somebody having a cervical fibroid, which is a fibroid that's located very low down into the cervix. And sometimes when folks have undergone surgeries where they've had fibroids removed, which we call a myomectomy, sometimes pieces of that can actually get deposited into other areas and other organs of the body, and it can actually, interestingly, grow its own blood supply and survive in that way. So this is just a demonstration of a piece of fibroid that has gotten into a place of the body called the broad ligament, which is the tissue that's almost out to the sides of the uterus. And so I like to keep things interactive. I think it keeps people thinking and helps you remember things. And so what I'm going to ask for you to do is I want you to take about 30 seconds to read the question. And then what we're going to do is I want you to put your answer in the chat, but don't hit enter just yet. Okay, so 30 seconds, type your answer, but don't hit enter. We're going to release our answers all at one time. All right, maybe about 10 to 15 more seconds. Okay, 3, 2, 1. Go ahead and release your answers. Okay, great. All right, well, yeah, thank you all so much for those answers. So yeah, actually all the above. Symptoms can range from absolutely no symptoms whatsoever to any combination of basically B through E. Okay, and so yeah, there's a wide range of symptomatology. So interestingly, though, fibroids are the sole cause of infertility in only about 1 to 3% of cases. So that may not be as common of a cause of infertility, but still is a potential cause of infertility. So how do we diagnose fibroids? Well, of course, we start with speaking to the patient about what is happening. A lot of times patients will seek care for heavy bleeding, pelvic pain, pelvic pressure. They may be going to the bathroom and going to urinate very frequently. So we typically understand what the symptoms are that the patient has concerns about, and then perform an exam, usually in conjunction with a pelvic ultrasound, which typically is the gynecologist's and the obstetrician's imaging modality of choice. And so coming to our pictures here, I included a couple pictures here. So this is looking at the uterus almost like you're looking at somebody from their side. We call it a sagittal view. And this is with a probe that's placed into the vagina. So we call this a transvaginal ultrasound. To orient you, the top of the uterus, or what we call the fundus, is up here. And the cervix is down in this area. And we see the kind of this dark black line that turns a little bit white here. This is actually the endometrial lining, which is the lining that lines the cavity of the uterus. And then what's being measured here, this little bit darker gray, I know it all looks like shades of gray, but this little bit darker gray area is actually a fibroid. Okay, so they're typically going to have kind of the same level of grayness as the rest of the normal myometrium or muscular layer of the uterus. Okay. Now, this next image that you see here is still a transvaginal ultrasound, but it's a little bit more specialized of a transvaginal ultrasound. In this circumstance, we've done what is called a saline infusion sonogram, meaning that we've introduced a small, thin catheter through the cervix to the inside of the uterus. This is a B for balloon. It's just a balloon that's been blown up on the end of the catheter. And a little bit of sterile saline water has been pushed or injected into the uterus to help to separate the walls. So this ultrasound here, you can see we can't see any space. We can't actually see the space of the endometrial cavity or the inside part of the uterus. Injecting the saline water lets us see, lets us separate the walls of the uterus, and we can actually see that there is this fibroid that's in between these two arrows here, and it's coming down into the cavity of the uterus. So it gives us a little bit more information about the location of the fibroid. Okay. Sometimes we use MRI if we are looking for, in a patient who maybe has multiple fibroids, or if we're trying to plan for a myomectomy, which is just a removal of the fibroids, okay? So those are typically the imaging modalities of choice that we use when we're assessing fibroids. So moving on to management. So there's many options to manage fibroids. In the patient who doesn't have any symptoms, you know, there may not be any treatment that's necessary. Patients may be watched at their annual well woman exam with a pelvic exam. If there's, no change in symptoms or the size of the uterus, then there's no need to necessarily do repeated annual pelvic exams. Typically, that's something that I incorporate if a patient is coming to me saying, you know what, Dr. Stuparich, something's changed. I feel a heaviness in my pelvis. My periods are getting heavier. I'm having to urinate all the time. And so the ultrasound we kind of use as a check-in to see how are things when it comes to the fibroids. Medical options, the great news is that we have both hormonal and non-hormonal therapies for patients. Not all patients are candidates for these medications. And, in order to get into a real in-depth discussion about the medications, that's probably beyond the scope of this talk in particular today. Suffice it to say that if you, do have fibroids and are going to be managed, then this will probably be a component of the discussion that you would have with your physician. There's also an option for an interventional radiology procedure that is called a uterine artery embolization. Another name for that is also a uterine fibroid embolization, and I'll get into more in-depth discussion in just a moment. And lastly, there are, conservative surgical procedures using energy to treat the fibroids, and I'll discuss in more detail later, as well as surgery to remove the fibroids alone, which we call a myomectomy, or remove the entire uterus, which is a hysterectomy. Okay, so now I'm going to go ahead and move on to discuss the interventional radiology procedures and the ablative procedures. Not to be confused with ablation of endometriosis, which we can get into in the second part of the talk, okay? So a uterine artery embolization, which you can see pictured here, is a procedure that delivers little tiny spheres of a synthetic material into both of the uterine arteries. So the uterine artery, you can see here, is the main blood supply to the uterus, okay? And so what happens when you put these particles into the uterine artery is that the blood flow becomes obstructed, which ultimately results in a significant decrease in blood flow to the uterus, which can cause basically what we call necrosis in the medical world, or cell death of the fibroids. Some of you might be wondering, well, wouldn't that hurt the entire uterus? So what typically happens, and the reason why this works in the setting of fibroids, is that there are actually larger caliber diameter blood vessels feeding the fibroids. So the particles actually preferentially gravitate towards those larger blood vessels and selectively block the blood flow to the fibroids. Okay. Interestingly, the catheter can be put through the femoral artery, which is kind of at the groin area, or they've even done it through the radial artery, which is at the wrist. Okay. So, who is not really a candidate for this procedure? So anybody who wants to become pregnant later on, anybody who has one of those pedunculated fibroids where it's kind of sticking off the top of the uterus or hanging down into the cavity of the uterus. The reason why is because when we do the embolization, it can actually first cut off blood flow to the stalk, or that stick that the fibroid is sticking off of. And so these fibroids can actually come off of that stalk, and you would either have a fibroid kind of freely rolling around inside your body, which is not good, or freely rolling around inside the uterus, which is also not good, okay? Most patients are typically admitted to the hospital for maybe 24 to 48 hours, and up to a quarter of patients develop what's called a post-embolization syndrome, where they might have some worsening of their pelvic pain, they may have some associated nausea, low-grade fevers. If patients do have this, then the way that it's managed is typically using pain control as well as other supportive measures. So compared with a hysterectomy, so let's kind of put the two side by side, a uterine artery embolization has historically been associated with a shorter hospitalization, but only if the patient doesn't go home the same day from hysterectomy, which the vast majority of hysterectomies that I'm performing are a minimally invasive hysterectomy, and patients are typically being sent home the same day. Okay. Oops, skipped ahead here, one moment. Okay. So About 26 to 37% of patients who undergo this procedure will require a subsequent procedure, which in a lot of cases may in fact be a hysterectomy. Okay. If a person were to become pregnant after this, these pregnancies can be more complicated and a higher risk just because the uterine blood flow has been compromised in this case. Okay, so again, that's another reason why we're not recommending this for folks who want to preserve their ability to become pregnant. Now we'll move on to the radiofrequency ablation. So this is not a particularly new technology in existence. This had actually been used to treat benign growths in the liver, but this has now been extended to being a reasonable treatment modality for fibroids. So the name of the first radiofrequency ablation system that I'm going to discuss is called Excision. This is actually a laparoscopic procedure. So this is performed in the operating room using small incisions and using a very specialized, basically radiofrequency array that using ultrasound guidance, you help yourself to place it within the fibroid. Okay. So this, the early evidence for this shows patient symptom improvement and a reintervention rate of 11% at about 3 years out. So they're still collecting data on this and trying to understand what role, this plays. There's not a lot of data regarding long-term symptom relief, fibroid recurrence rates, and effects on fertility and pregnancy, because as I mentioned, this is a relatively new application of the technology, despite the fact that it's been around for a while. This is considered to be a uterine sparing process. So the fibroids are being preferentially treated while the uterus is remaining within the patient. And so this is one way that we can apply it. And again, this is done through the abdominal wall using small incisions. So similar to, a laparoscopic surgery, but the difference is that whereas in a hysterectomy, you're removing the uterus, in this particular case, the uterus is staying behind. So contrast that with this other type of radiofrequency ablation called Sonata, which I, for lack of a better term, and the reps probably don't like me saying this, is kind of Excision, but applied through the cervix, okay? So this has the potential to be completely incisionless, so no incisions on the belly, but utilizes the same general approach of using ultrasound to guide where you place the probe to deliver the energy that essentially necroses the fibroid. Okay. Again, this is a newer technology, so they are in the process of gathering long-term data. In particular for the Excision, I did want to make a point. It's usually not applicable. It has not actually been studied in patients whose uteri are larger than 14-week size. So when we talk about the size of the uterus, we talk about it in relationship to how big we would expect a uterus that is pregnant of the same size. Okay, and we have different markers on the body that we use to understand that sizing. So anybody who has a uterus that's larger than what we would see at 14-week size is we don't have data to support that use at this time. And we also don't really have data to support the use of either of these two technologies in women who are wanting to preserve their ability to become pregnant. Myomectomy is a uterine sparing procedure where just the fibroids are removed. And so you can see some illustrations here of that I will walk you through. This is usually reserved for those women who desire to preserve their ability to have children. This is due to the fact that the risks of the procedure are essentially equivalent to undergoing a hysterectomy, okay? And in some cases, arguably maybe higher for some women, depending upon the size and the number of fibroids. I usually perform this procedure in a minimally invasive fashion through small incisions, but whether or not the procedure is performed through small incisions will depend upon the surgeon's experience, in addition to the number of fibroids, the location of the fibroids, and the size of the fibroids. Okay, and it's essentially an individualized decision that the patient and the surgeon would make together. Okay, And so here we see this is the top of the uterus, or that fundus that we talked about earlier. We're using an energy instrument to make an incision to access the fibroid. And then we're using that energy instrument to gently take the fibroid out. And then we have to sew it back up. Okay, so that's typically what happens. Women, when they have this procedure, do need to have a cesarean section for delivery. The reason why is because when that uterus starts to contract and during labor, there's a much higher risk that these incisions, even if they've been closed perfectly, can inadvertently rupture open once labor starts. Okay, and so that is a huge risk that requires an emergency surgery. The placenta can separate prematurely. And so in order to mitigate or lower that risk, we typically recommend delivery by C-section. Hysterectomy is considered to be the definitive treatment for fibroids. It removes the fibroids and their source, the uterus. My primary approach for most hysterectomies is the laparoscopic approach, which is considered to be a minimally invasive approach. But a hysterectomy can also be performed vaginally, or through a large abdominal incision. Although if somebody is telling you that you need a surgery with a large abdominal incision, that may not be, you should probably question why. And so for me, every patient is a laparoscopic candidate until they prove themselves not to be, okay? This picture that you're seeing here is a little bit misleading in the case of a fibroid uterus because it shows the uterus being removed through the vagina. Okay, so this is a patient on her side and the uterus is effectively being removed through the vagina. In many cases with fibroids, the uterus is too large to be removed through the vagina. And in these circumstances, I usually introduce a medical grade bag into the abdomen and place the specimen within it and then remove it in smaller pieces with the bag there to help contain any pieces that might fall off. Okay. If you just went on Google and typed in hysterectomy fibroids, you would probably come across very unfortunate, controversial, situations that happened in the past through using a device called a power morcellator. This was basically a very high-powered device that would spin very, very fast with a circular blade on the end of it, and we would use it to extract the uterus from the inside of the body. A lot of times this was not done using a bag to try and contain it. And so this is not a device that we use anymore. There were many safety concerns that were raised with this. So I wanted to make sure that I addressed that. Okay. So comparing myomectomy versus hysterectomy, all of the same risks of surgery apply with both surgeries. And hysterectomy is definitive, so it's considered to be kind of the end of the line. It's most likely, in most cases, what is going to remove fibroids from the body and potentially prevent them from occurring again. Okay. Myomectomy allows us to potentially preserve fertility. There is always a risk of having to have a hysterectomy during a myomectomy. There's a higher risk of having scar tissue form, and the fibroids can either recur if they weren't all taken out, or maybe there was a fibroid that was much too small to see either at the time of surgery or on imaging, and so that can grow, over time as well. But the main factor that factors into whether we do a myomectomy or hysterectomy is whether or not the patient desires to preserve her ability to be able to have children. Okay, but it is a lot more nuanced of a decision than just that kind of one black and white point. Okay. So these are actually misnumbered, but this should actually be take home point number 1. So there's many treatment options for fibroids, and make sure you discuss them with your gynecologist. Okay. So with that segue, we will move on to speaking about endometriosis, which is the other half of our presentation today. So a couple definitions. Endometriosis is the presence of endometrial glands and stroma outside of the normal location, and it is diagnosed surgically. Okay. This is a picture here just showing, a lot of the scarring that can happen. So this is the cervix, the vagina, this is the uterus, and you can see all these kind of webby pieces of tissue connecting everything to everything else. And this is not normally what the uterus and the cervix and the ovaries look like. Okay. Symptoms may be pelvic pain with periods, pain with sex, pain with a full bladder when urinating, pain with having bowel movements. So when I teach students about this, I talk about the 4 Ds, and these are the medical terms for this. So dysmenorrhea, dyspareunia, dysuria, and dyschezia. Sometimes endometriosis can present with even non-cyclic pain. And a lot of times this may happen when things have gotten quite bad, when the disease has spread to where it's impacting neighboring organs. Endometriosis can be responsible for infertility. And if it's so bad and so progressive, sometimes endometriosis can cause obstruction of the bowel. So patients can have a lot of gastrointestinal symptoms, or sometimes it can basically kind of choke off the ureter or go eat right through it, which is the ureter is the tube that connects the kidney with the bladder. Okay. So if we were in person, I would have us all stand up and say that painful periods are not normal. Pain that keeps teenagers home from school, pain that keeps women home from their jobs or unable to care for their children, family, perform the functions of their job is absolutely not normal. When people have to excuse themselves from daily life, they have to call off of work, when they have to call their moms to come get them from school, this is actually a medical term called absenteeism, and has repeatedly been shown to be associated with a diagnosis of endometriosis. And I think it's very important that we pass along this message that painful periods are not normal. There is a well-studied and proven culture that it's overall more acceptable for women to be in pain than men or other comparison groups, and also that women are taken less seriously when they say that they're in pain. This culture needs to stop immediately. We need to spread the word that there are also specialists who treat chronic pelvic pain, and in particular endometriosis. So I would encourage you that as you walk away from this presentation today, that you carry that forward and help to educate others. All right, and so we're going to go for our next pop quiz. And so same thing applies before. I'm going to give each of you about 20-30 seconds to read the question. Go ahead and enter your response in the chat, but then don't push enter until I give you a 3, 2, 1, okay? All right, so what is the prevalence of endometriosis in reproductive age women? So think of your answer, and then I'll give you a 3, 2, 1, and you can enter it. Okay, so 3, 2, 1, enter. Okay. All right, so for those of you that guessed B, you were correct. Okay. All right, same thing, take 20 seconds, think of your answer to the question, what is the prevalence of endometriosis in infertile women? Okay, 3, 2, 1, go. Okay, a little bit more of a spread maybe. So we're ratcheting things up. So it's actually 38% in women who have been diagnosed as having infertility. Okay. Now, last question in this vein. So what is the prevalence of endometriosis in women who have chronic pelvic pain? Chronic pelvic pain, the definition is actually just having pain in the pelvic area for more than 6 months. Okay. So 10 more seconds. Okay, 3, 2, 1, go. Okay, yeah, more on the higher end there. So if you answered C, then you were correct. Okay, so we can see as we select patients who have known issues that endometriosis can cause, then our prevalence of finding endometriosis in that patient population goes up. Okay. When I'm teaching my medical students, I like to bring up the patient perspectives, and that it is well studied that delays in diagnosis are very common, and it can be so much longer than what you may consider. So delays in diagnosis of around 4 to 11 years is very common. And delay is exacerbated by what we just spoke about, the fact that these menstrual symptoms are normal or considered to be normal. And that's, sometimes I think, your relatives might be coming from a place of like trying to be empathetic, but it's not okay to have periods that keep you at home. It's not okay that you would have to leave school. It's disruptive to your education. It's disruptive to you potentially earning a living for your family. And so that thought process has to stop. And a lot of endometriosis, the symptoms that it may cause may masquerade as a lot of other things. And so a lot of times women will get other diagnoses as they are undergoing their workup. And so, the things that this diagnostic delay can cause they are very significant. First of all, quality of life is decreased, okay? This unfortunately can breed a lot of mistrust between a patient and her physician, especially if she's having to see multiple physicians who don't really seem to be understanding what she's trying to communicate. And if you have that happen to you repeatedly, then you may become mistrustful or distrustful of the entire medical community, because it's really tough to continue that fight, as you go along. The concept of something called central sensitization, I'm not going to get into with any particular depth, but it is something that has been studied that people who are in pain for a long amount of time may have changes in their nervous system that predispose them to something where it would be just a normal sensation that you might feel may actually become painful to them. It's not something that I think should be the end-all be-all cause of somebody having pain that maybe is not responding to treatment. I think it's more something that needs to be understood, that may come with the territory and just contributes to the whole picture of pain when it comes to a patient. Okay. In addition, let's not also forget that during the time that we're trying to get diagnosed, the disease may be progressing, which can cause more damage and scar tissue formation, which could ultimately result in more pelvic pain and potential difficulties in getting pregnant. Okay. So this was a cross-sectional survey of around 640 individuals who sought care for menstrual pain, non-menstrual pain, as well as pain during sex. The mean time from the start of symptoms to getting a diagnosis was 4.4 years. The mean time to having their first consultation with a practitioner for women in their 40s was a little over a year, but women who are adolescents was basically 3.5 years. Okay, so huge difference there. From the mean time from first consultation to getting a diagnosis, again, women in their 40s was about a year. But again, those poor adolescents, it took them almost 3 years to actually get a diagnosis. Okay. Sometimes, patients will have questions about, well, is there like a minimum age, that you would consider potentially doing a surgery on a patient? The answer is that every patient needs to be evaluated as an individual. The patient brings their values to the table. I bring the medical expertise, and we have a discussion together as a team. When it comes to age, that's a very arbitrary cutoff. And so there's not necessarily a minimum age under which it's like, oh, nobody under 18 gets endometriosis. We know that that's not true. And so, I think it's very important to understand what the patient's values are, what their goals are moving forward, and put that all together. And in the case of adolescents, you probably would need to involve the parents. But it's important to make sure that all these things are discussed. Okay. So treatment or management options for endometriosis. typically what we talk about is the fact that, yes, endometriosis is not a life-threatening condition, but it is 100% a quality of life impacting condition, okay? Because it's not a life-threatening condition like a cancer, some people argue, I'm not one of those folks, that could you manage it expectantly? Well, yeah, but most patients would continue to be in whatever state they are in, and that's typically the reason that they have made the appointment to come and see me, is that they're no longer satisfied with managing it expectantly. Okay, but I always like to present a full array of the management options. Medical management, there may be some options in the appropriately selected candidate. The thing is with medications is that they're all managing symptoms, and so they could be viewed as palliative. They're managing symptoms. There has not been proven or discovered to be any particular medication that just miraculously makes endometriosis dissolve away. Okay, I mean, I wish that was the case, but it just is not existing at this point. Okay. So, but in order to have a full scope discussion, sometimes hormonal therapy like birth control pills can be used to manage symptoms. There, are these other medications that get discussed called Lupron and Orlissa. These medications effectively put you into a chemical menopause. Okay. A lot of times when it comes to, endometriosis treatment, again, these medications have not been proven to make endometriosis miraculously disappear and a person just returns to, a normal state of living. This may be, these may be appropriate in a very, I think, very narrowly selected patient population. But I think in the vast majority of patients who are candidates for surgery and have a potential to gain a lot of benefit from surgery, a lot of times these medications are kind of like putting a Band-Aid on a compound fracture. You ever seen cartoons or hopefully not a real fracture, but cartoons where the bone is sticking out of the skin? Imagine just putting a Band-Aid on that. It's not really addressing the problem appropriately. And so, the other thing is that we have very limited periods of time that we can use these medications. So Lupron, a lot of times we can't use it for any longer than 6 months without giving hormones back. Orlissa, that's between 6 months to 24 months. And then a lot of times patients are very young. They're not about to go through natural menopause. And so then what do we do once we've exhausted that 6 to 24 month period? We're kind of back at square one. And these medications do have a lot of side effects that come along with that induction of menopause. Okay. So again, everything is a discussion between the physician and the patient and the values moving forward. But, of course, there's real risks and benefits with everything. Then we move on to surgery. My approach surgically is to do a minimally invasive or laparoscopic excision or cutting out of endometriosis. That can be contrasted with potentially using energy to burn the lesions of endometriosis, and we will get into that in a little bit more detail. Hysterectomy, it's a very outdated thought process that hysterectomy cures endometriosis. Hysterectomy may be a reasonable treatment option for a uterine source of pain. Endometriosis, really by definition, is ectopically located abnormal tissue, okay? And so it's really located outside of the uterus. There can be a somewhat related condition to endometriosis called adenomyosis, which is where that lining of the uterus starts to invade into the muscular layer of the uterus. So that same layer where fibroids come from, the myometrium, gets invaded by the lining of the uterus, and that can cause pain and heavy bleeding as well. So it's not uncommon that we may see those conditions together. But yeah, hysterectomy purely for treating endometriosis is it's not really even a logical management strategy. For uterine source of pain, different story. Okay. So we'll talk a little bit about laparoscopic excision of endometriosis. I'm going to show you all some pictures of some of the things that I see at the time of surgery. But basically, the lesions that we're looking for of endometriosis can be highly, highly variable in how they appear. It can also depend on the patient's age. And so some of you all that may have familiarity with the disease from either doing research or personal experiences, you may come across the terms like powder burn lesion or gunpowder lesion. And this is kind of classically how it's taught and seen. And so just to kind of orient you, we're zoomed in really close, looking underneath the left ovary. The rectum is over here, so the bowel, okay? The uterus and the cervix is over here, okay? This is a ligament called the uterosacral ligament that connects the sacrum, which is your lower backbone, with the bottom part of the uterus, and endometriosis tends to like to be here a lot. This is the ovary that actually has a little bit of endometriotic or chocolate fluid kind of coming out of it, okay? But you can see all these little kind of gray, scarred, black lesions here. These are all lesions of endometriosis. And when you start to cut into these, little bursts of like that brown chocolate fluid may come out. Now, when we're doing an excision, we like to try to provide a margin around here. Okay, so we're cutting out all the visible lesion, basically out to normal tissue. And so that's the goal of an excision surgery. This is a little bit more extensive powder burn type of lesion, kind of looking in that same area that we were looking on the last slide, just a different surgical photo. What I didn't point out before is that the ureter, which is the tube that connects the kidney with the bladder, for whatever reason, endometriosis also very much likes the ureter as well. Okay, and so this is basically a larger plaque of endometriosis. So what we would do is basically provide a margin all around this and essentially peel this out to normal tissue. Okay. Coming over to the other side of the body. So we were on the left side of the body before, coming over to the right side of the body. You know, as I mentioned, they can have somewhat of a different appearance. So this is more of a red kind of vesicular appearing lesion. You don't really see a lot of that classic powder burn lesion that you saw on those last two slides here. And so this is something that, you know, I would remove as well, okay? And so understanding what the variability of the appearance can look like is really important. So here you can see the uterus and the cervix are over here, that ureter, which is the tube that connects the kidney with the bladder, a little piece of the ovary over here, okay? And then this is just one of our laparoscopic instruments here, okay? All right. So we're going to talk about the concept of something called excision versus ablation. So I mentioned that, you know, there can be two sort of general approaches to how to address this. First is the excision, which is, again, basically where you're lifting up that piece of abnormal tissue that you're suspicious is endometriosis, and you're using sometimes energy, sometimes just a sharp end of a scissor to cut around it. And then that gets removed from the body, gets sent out to be a specimen to be looked at by a pathologist. Versus, what if I just used energy to burn that lesion? Okay, so these are the processes that I'm comparing and contrasting right now. So it's my my belief that is supported by evidence that excision is my preferred method of removing endometriosis, and there's a couple of reasons why. So there are a lot of studies that support excellent outcomes in pain improvement with excision versus ablation. Excision gives us a chance to have a piece of tissue, okay? Why is this important? Well, this is important because, well, number one, endometriosis is diagnosed surgically. Number two, we're not as good as we think we are at visually identifying endometriosis. That's why it's important to do these excisional biopsies so that we can either have the pathologist confirm or deny that it's endometriosis, okay? Sometimes it can be leftover scar tissue. It can be leftover scar tissue from another surgery. Sometimes it can be burn marks from another surgery. And so I think in the hands of folks who don't do this surgery a lot, they're about, you know, they get it right about 41% of the time. For those of us who do it a lot, we're right about 81% of the time, but that's about 20% of the time that we may not be correct, okay? And so, well, what does that matter? Well, incorrectly diagnosing a patient with endometriosis based on a visual inspection alone could, number one, cause a lot of anxiety in the patient, could cause some unnecessary treatments to be performed. And there can be a lot of stigma that's associated with the disease, okay? Excision also offers us the opportunity to assess that we've completely removed the lesion. So just because something looks like it's just sitting on the surface of that skin area that I was showing you, doesn't mean it doesn't extend deeper in, okay? And with ablation, they say you should burn to normal tissue. Well, how do you know that you've reached normal tissue? Secondly, you've also burned your specimen. So, it seems, might, seem like common sense, but these are important things to consider, okay? Excision also provides a margin around the implant. And so the margin around the implant, so when we have, a good 0.5 centimeter, 1 centimeter margin around that abnormal spot that we see there, some of those margin areas may actually have microscopic or occult disease that we just can't see with the laparoscope. It would only be seen on microscopic evaluation, okay? And then lastly, the ablation or burning can cause carbon deposits and white scar tissue that can actually mimic endometriosis and make for a confusing clinical picture. And, since we don't know exactly how far the energy may extend into surrounding tissue, we do run the risk that if we've, discharged that burning for a long time, that we could hurt nearby things. So the ureter can be close by, the bladder can be close by, the bowel can be close by, arteries and veins. And so, that heat of the burning can travel quite far and it can cause harm. Okay. So this leads me to, oh yeah, I remember I switched these segments, but I did fibroids first now and endometriosis. So, but it was reversed before. But take home point is that painful periods are not normal and there are specialists that can evaluate and help you, okay? So some resources that I like to share with folks, there's an International Pelvic Pain Society for those folks who have chronic pelvic pain. Nancy's Nook Endometriosis Education group this is a Facebook group that is you would have to be admitted by an administrator, but it's a curated resource that patients can use to basically research in an evidence-based fashion, ask questions. It's meant to be a self-directed learning library and has really been a great help for a lot of patients. So that may be something that you can check out if you're active on Facebook. I think this is starting to be extrapolated onto a web page as well, but the bulk of the group is still managed through Facebook. Okay. So just to reiterate the take-home points, many options for treatment exist for fibroids. Discuss with your gynecologist and shout it from the rooftops, whatever you have to do. I wish I could put up a billboard. Painful periods are not normal, and there are specialists who can evaluate and help you. Okay. So with that, I'll go ahead and just have some contact information here. And then my references are on these next two slides if any folks are interested, but go ahead and leave my contact information and we'll go ahead and open it up for any questions.
Thank you, Dr. Stuparich. I'm just waiting to see if anybody does have a question via chat.
Sure, sure.
All right, they're slowly coming in. So the first question is, do you have any information about, I'm going to mess this up, but it's the
Inguinal?
Yes, endometriosis.
So inguinal endometriosis is, I'm thinking that that's probably endometriosis that might be extending down into the inguinal canal. And yeah, so I mean, there have been reports of, having endometriosis that kind of goes down the round ligament, which is the ligament that extends down into the inguinal canal. Endometriosis is one of those disease processes that it really knows no boundaries. I mean, they now have published that they found endometriosis in basically every single organ. Okay. And so it used to be that it was everything except the spleen. Oh, thank you for sharing the context. And so, I think that when you're looking for somebody to look into the endometriosis, it's important that they feel very comfortable with pelvic anatomy. And, it's important to be able to I mean, really, yeah. I mean, surgery is basically, it's an exercise in pelvic anatomy every time that you go in. And so I think it all just depends on what is presented with you. I think that specifically in the context of continued pain, it's never a bad idea to have another opinion. That way, sometimes a fresh set of eyes can help review things and come up with, management options that are most appropriate for the individual. So.
Thank you. The
Yeah.
next question would be, Lisa, what could cause sciatica pain with endometriosis?
Yeah, I mean, there's a lot of overlap with the nerves that are in that area. And so, have I seen deep, endometriosis that could be infiltrating to the sciatic nerve? Yes, that's possible. I think the fact that there's so much shared innervation with all the organs there leads to a lot of the reason why patients may have overlapping bladder symptoms, overlapping bowel symptoms. And so, yeah, it would take a team that has experience with, dissecting in that area to determine whether or not there's evidence of disease in that area.
Thank you.
Mm-hmm.
The next question is, what qualifications should you look for in an endometriosis surgeon?
Yeah, that's a great question. So, I think that you would want to be asking your surgeon how many procedures of this are they doing, in a month, in a year. I think that is a good context. I think that it is important to have a surgeon that really has a focus and really an interest in, and almost like a passion for this, because that's what you want your surgeon focusing on, like, all the time, is managing surgical issues. Okay. And so it really speaks to just the importance of volume and doing these surgeries on a repeated basis.
Thank you. The next one is, if you have a surgical diagnosis of endometriosis and it was excised, how do you prevent reoccurrence after surgery?
So this is something I do talk about quite a bit with patients, is that what we know from the evidence is that patients who use what I will call hormone therapy after surgery, so either some sort of like a progestin hormone, some patients it's combined birth control pills. It's patient dependent, but what we know is typically those patients go a longer time without having symptoms than those who don't. Now, we always have to balance, though, does someone tolerate hormone therapy well, and are they a candidate for it? So if the risks from that standpoint outweigh the benefits, then it may not be reasonable for somebody to consider that. But I think, the primary prevention is having, an appropriate excision surgery where someone has looked very closely. I've been taking to incorporating into my practice, doing wide excisional biopsies of the areas where I know endometriosis commonly lives, because sometimes that disease can be microscopic. And so that, helps us know. It also helps me be able to tell a patient, what, I took the biopsies and there wasn't anything there. And sometimes that can be a little bit bittersweet for a couple of reasons, because, sometimes if a patient is very focused on having a potential diagnosis, only for me to tell them, no, that's not, what's going on, it kind of, throws you for a loop a little bit. But I look at that in that patients may have now that cognitive freedom to just cross that off their list so that they can pursue other things that may be the causes for their pelvic pain. And it is the rare, if not almost the non-existent patient that just has one single thing causing the pelvic pain. A lot of times it's multiple contributing factors that all need to be managed with a multidisciplinary team.
Thank you. The next question is, are additional causes for fibroids and endometriosis still being studied?
Yeah. So, yeah, I mean, there's ongoing studies in all of these, in both of these arenas. I know where I did fellowship, they were looking into more basic science research, which is more like bench research and, genetic things and identifying genes that may predispose somebody, identifying markers on endometriosis and things like that. So yeah, there are very active areas of research. And I believe actually the federal government signed it's either a grant or something into play that I think the vice president was supportive of championing fibroid research. So they're both very active areas of research. And, hopefully we'll be able to find out some more things and maybe some even more minimally invasive ways to diagnose things and other treatments. That would be great. And then I see the second question, when stitching the open area, what is the thread made from? So, the suture could be made of several different things, but most of the time we're using something that is absorbable within the body. Of course, it wouldn't be practical to have somebody come in to get their stitches taken out. But usually it's something that dissolves over the course of several months. And sometimes it can kind of retain itself. Other times we have to tie it. But I'd have to look up the exact specific materials, like the scientific names, if that's what you were interested in. But most of the time they're an absorbable component. Hopefully that answered your question.
Thank you. Do you want to read through them?
Yeah, I can read them. Yeah. So you said that endometriosis is the same as the lining of the uterus. So I have heard it as tissue that is similar, but not the same. Yeah. So there's a lot of nuanced ways to think about that. I say that it can be microscopically identical. That doesn't mean that it behaves in the same way, which is, one of the reasons why birth control may not be a true treatment. Okay. And so I think it's very important to make that distinction. There's more nuance there. So I appreciate you bringing that up. Because, we can have patients who are on birth control for years and they have progressive disease because it does not behave in the same way as the lining of the uterus. Okay. Okay, Lisa asks, how often percentage can you see possible endo via ultrasound, MRI, and CAT scan? So, yeah, so those are a lot of the very common imaging modalities that are used in medicine. Ultrasound is very good for diagnosing endometriosis that's deeply infiltrating on the ovaries, or endometriomas or endometriomata. It's not the most sensitive for superficial disease. And so it might be missed if you're just using pelvic ultrasound to scan for superficial disease. MRI, I like to use as an adjunct if I'm looking into endometriosis that could be deeply infiltrating into surrounding organs like the bowel or the bladder. So it's really hard to give an exact percentage, but just because someone's pelvic ultrasound or MRI is totally normal, if they're having ongoing pain, then in the vast majority of cases, it's very reasonable to offer what we call diagnostic laparoscopy, which is where we use the camera to look inside the abdomen and pelvis for any endometriosis, because ultrasound and MRI are not 100%, they are not really at all specific for very superficial disease. That being said, degree of disease does not correlate with degree of pain, okay? And so somebody could have stage 1 or 2, which is considered to be a milder severity, but still be debilitated with pain. And conversely, you can have people who have moderate to severe or stage 3 to 4 endometriosis, and they're doing relatively fine. So there's no correlation between that. So a negative endometriosis or negative ultrasound or MRI for deeply infiltrating endometriosis does not at all rule endometriosis out. Okay. Okay, what are your thoughts on how education about medical conditions related to menstruation, such as endometriosis, can be increased in the country? So yeah, this is challenging because I think that, it would be great if students were taught this in school, but there's a lot of sensitivity around just sex education, reproductive health education in schools. And I think it could be worlds better. There is a nice push, I forget the society, so you'll have to forgive me, but nice push for a particular society seeking to educate school nurses. So those folks are going to be frontline for seeing these adolescents who are coming in every single month debilitated with period pain. So, they can provide, some education both to the, student as well as the parents. But do I think more needs to be done? For sure. For sure. That's why one of the lessons that I want my students to leave the OBGYN clerkship with, if they're rotating with me, is that painful periods are not normal. And if you don't feel comfortable managing a patient who has that, that's okay. And there are people that can help you. So please send those patients to the appropriate person. Okay. Okay. Let's see. All right. I found this as prevalent excessive bleeding for my pain, beetroot. Okay. Okay, so I found this is perfectly effective for my excessive bleeding per month and for my pain. Okay, 10 days of 1 gram of beetroot followed by 16 days of 5 milligrams of norethindrone. Have you heard about this combination treatment? So norethindrone is a well-studied medication in the gynecology world. It's beetroot that I'm not completely familiar with. So yeah, norethindrone is basically a progestin. And so that can potentially have a decrease in the amount of bleeding that somebody might have. I don't know what the addition of the beetroot would either add or take away. So that would be something that I would need to educate myself on, because we're all learning all the time. Gotcha.
All right. Thank you everyone for joining us today. I appreciate you taking the time out of your day, as well as Dr. Stuparich for also walking us through each of these topics. If you have any questions once the presentation ends, feel free to reach out to marketing@medschool.ucr.edu, and I'll be sure to connect your question with Dr. Stuparich. And just as a small plug, if you're interested in more health topics, the What's Up Doc also addresses additional topics. So again, thank you everyone for your participation and have a wonderful evening.
Thanks everybody. Take care.